Thank you. It's a great pleasure to be here. I pride myself on learning something new every day. Today's lesson was never wear an outfit with fake pockets or you'll be attaching your remote mic in the bathroom to your bra before the talk. So, but we're all set. I feel like I'm on Survivor. Okay, do we have slides? So I'm gonna talk today, the title of my talk is Deciphering the Genome, Community-Driven Approaches, and really talk about how we're working as a community to help solve some of the challenges we have. But it's not. All right, I'm gonna. Okay, there we go. So just a couple disclosures. I am an employee of Brigham and Partners Healthcare. We offer genomic services and receive royalties from sales of Gene Insight, now owned by Sunquest as of 2 days ago. And I'm an employee at Broad Institute, which also offers fee-for-service molecular diagnostics, and I receive NIH funding for a number of grants. So I'm going to start talking about one of the projects we've worked on for a few years in collaboration with Robert Green called the MedSeq project. And this project involves enrolling 200 patients, all of whom have been enrolled at this point. Half of them had hypertrophic cardiomyopathy, an inherited cardiology phenotype, and half were healthy. And they were co-enrolled with their cardiologists and their primary care physicians, and then randomized to receiving whole genome sequencing or standard of care with a family history taken. My lab then did all of the interpretation, issued the clinical reports, and then we did a lot of follow-up studies, interviews of patients and physicians, we recorded disclosures, and we learned a lot from this study. One of the things that we started with was how do we take everything we can learn in a genome and put it into a report that could be consumed by a primary care physician or a cardiologist. So we developed a one-page overview of the genome, identifying monogenic disease risk, things like breast cancer risk, carrier status, pharmacogenomics, and even blood cell, platelet, and antigen prediction. So that was the overview on the first page, and then we would have subsequent pages where we could go into depth about the evidence for the variant's pathogenicity, what disease we were talking about, explain what that disease is and the familial risk, contextual information about the pharmacogenomic variants and what dosage of drugs was relevant for those particular pharmacogenomic alleles. So we've since enrolled all 200 patients, analyzed all of their genomes, looking at over 7,000 genes for Mendelian disorders as well as pharmacogenomics, complex traits, et cetera. And what did we find? So about 21% of the patients had some variant for a Mendelian disease. Almost everyone had carrier status. And for those who were in the cardiology cohort, we identified the cause of their hypertrophic cardiomyopathy in about half the cases. Now, our list of what we returned for secondary findings was much broader than the American College of Medical Genetics list, which is why we got a much higher rate. So now, challenge here is the process of identifying the variants that we identified in these patients was enormously labor intensive, especially when we started this 4 years ago, where each patient, who has 3 to 5 million variants in their genome, we'd have to go through extensive filtering to pull out variants. And of course, one of the ways we'd start was to pull out variants that were published as pathogenic in the literature, or were novel loss of function variants in genes that had been published with a disease association. That would give us 200 to 300 variants per patient that we would then need to review to decide if we believed those associations. Quickly, we started developing our own exclusion data sets to throw things out, whether they were technical false positives, genes that we reviewed where we believed the gene association was not even valid, and then even if the gene association was valid, that the variant was not pathogenic despite claims in literature. And anyone who's been doing this type of work knows that this is a lot of labor. There's a lot of false positive assertions in the literature about pathogenicity. And in the end, even after developing exclusion data sets from hundreds of cases, you still have a fair number of variants that are rare that you have to review in every case. And in the end, you report about 18% once you've developed good exclusion data sets. So in MedSeq, we report about 0 to 7 variants per patient after this process. In our BabySeq study, which is a little more stringent, about 0 to 2 variants per patient. So a lot of work for low yield. This is just a list of the variants that we identified in the patients for actual disease risk. we reported 3 different variant categories: pathogenic, likely pathogenic, and in this particular study, we included variants of uncertain significance if we at least favored a pathogenic return, as we were studying what patients and physicians do with uncertain information as well. So this was everything we reported back. You know, if you recognize some of these disorders, most of them are disorders that don't have full penetrance. This is why you might see them in a healthy individual or apparent healthy individual. However, we've subsequently been phenotyping these individuals to see if they have underlying disease associated with their findings. Those in green clearly have the disease. We definitely found patients being treated for hereditary hemochromatosis, an individual who had the eye disease associated with fundus albipunctatus. We found an individual who lost his hearing at age 30 and was wearing bilateral hearing aids. We found some indication of this skin disorder. We found a family history of Alzheimer's disease, though this individual was younger and not yet there herself. So in some cases, there's evidence of disease. In other cases, there wasn't. This individual got a full cardiac workup and had no evidence of long QT associated with Romano Ward. So of course, you know, the options are maybe it's not a pathogenic variant, or maybe it is and it's not fully penetrant, and it's going to take much larger studies to really get at these questions of true penetrance, as well as deciphering the pathogenicity of many variants that today we don't fully understand their significance. And I would argue that in order to improve our knowledge of DNA variation, improve consistency in how we classify variants, so the literature is much better resource, will require a massive effort in data sharing. And we published a paper about a year ago related to the new ClinGen effort, where we, you know, having worked with submitters to share their data through ClinVar, of the 11% of variants where there were more than 2 submitters, 17% of those variants were interpreted differently in data being actively submitted to ClinVar. So we clearly know that there's issues in how we as a community are interpreting DNA variation. This is no longer a surprise. The community, the media picked up this paper very quickly and has been, you know, talking about the issues in genomic interpretation. This was a story, and this has consequences for patients. It's no longer just did we or did we not diagnose the cause of disease that's existing in an individual. It's now coming down to predicting risk for disease and taking clinical actions based on the assumption that we're right about that. And this is a particular story that I contributed a case to that was, you know, a patient terminated a pregnancy based on a variant classified as likely pathogenic, when in fact the information that would have identified this variant as likely benign was not put out into the public domain and would have saved this fetus's life potentially. So there's very serious consequences for us not sharing data and not really being able to do this in a much more open manner. There's recently, about a week or so ago, a lawsuit is now pending related to the appropriate interpretation of genetic variants and whether that was done with enough rigor. So, you know, the world is watching and patients' lives are at stake. And not surprisingly, the FDA is also watching. And many of you know that the FDA is making moves to increase their oversight of laboratory-developed tests. There's a lot of public debate going on about this. The professional societies, such as the pathology organizations, as well as the genomics organizations, aren't thrilled about this and feel that this can be appropriately regulated in the traditional manner in which it's been regulated under CMS. But it's not clear that that is sufficient, and the FDA is making moves to increase its regulation of genetic and genomic testing. So, you know, what's the right answer? Will FDA oversight improve standards for genetic testing? Frankly, my own personal opinion is probably not. The detail and the effort that we go into this cannot be overseen daily by any organization. I don't care how much respect I have for them. This is a tough thing for us to do. And I would argue that we as a genomic community need to come together and develop our own standards for how we can ensure safe and effective use of genetic and genomic medicine. And it's going to require a lot of effort. And I would say that there's examples where this has worked. You know, the cytogenomics community, a number of years ago, we went huge expansion in the use of genomic technologies in in cytogenomics, moving from karyotypes to cytogenomic microarrays. That massive expansion of the market led to all sorts of commercialization of products that were very different in their standards. And luckily, the cytogenomics community came together as an organization, and they agreed on what were the appropriate probes to put into an array. And because they put out a standard, many of the commercial companies adopted that standard and said, you know, we use the ISCA design as a sort of shield of honor, like we, design this according to a standard. So I think that that's an example of where the community, if it puts out a standard, it will help allow all of us to do this in a more consistent and rigorous way. But those standards have to be developed, and they're not simple. We have been working within the ClinGen project to create standards within the interpretive process for genetics and genomics. So what is ClinGen? You know, our goal is really to create an authoritative resource that defines the clinical relevance of genes and variants for use in precision medicine and research. And we start with sharing data from all the different stakeholders, and then asking critical questions of that data. Is this gene associated with disease? Is this variant pathogenic? Is this information actionable for a patient? And really trying to document the answers to those questions in curated genomic knowledge bases. One of the knowledge bases we've been working on is ClinVar. We've also launched several other resources on our website directly, which can be found at clinicalgenome.org. This is a very large project, and I would argue we really need to, in essence, crowdsource this effort. We have already over 400 people from over 90 institutions working in work groups around this project, so it's getting bigger every day. These are some of the working groups that tackle different aspects of this project, which I don't have time to go into in depth, but suffice to say there's a lot of people involved. Now, I mentioned ClinVar is one of the resources that we work closely with. We've been collaborating with the NCBI team at NIH for over 5 years now, guiding the development of this resource as a useful tool for the community. So what do? We work with a lot of different groups, researchers, clinical labs, expert groups, clinics directly, patients directly, to share their variant interpretations into ClinVar. We also worked with other databases to exchange data between those databases that are more focused on different areas. As of March 21st, there are over 482 ClinVar submitters that have submitted nearly 180,000 variants, representing over 126,000 unique and interpreted variants. So in the last couple of years that this database has been around, we've been able to amass a fairly good resource. Now, you can go into ClinVar and type in your favorite variant, and sometimes, as I alluded to earlier, the overall interpretation may be conflicting interpretations of pathogenicity. But you can scroll down to the bottom of the page, and you will be able to look up who has said what about this variant. Some might say uncertain, pathogenic, likely pathogenic. There are dates when those assertions were made. Some may be very old, and perhaps you shouldn't trust something that's 10 years old. You can also click on the next tab and identify, in some cases, the evidence that that lab used to justify its classification. So at least it's creating transparency in how we are interpreting variants, the evidence we're using to do so. We've also launched a website. In fact, a 13-year-old son of Sandy Aronson, who will speak at the conference later, created this website. So with a little guidance, it's amazing what kids can do. So this website was created to actually take all the data from ClinVar that represents conflicting variant interpretations and organize it in a way that allows particularly the clinical labs to start to tackle differences in variant interpretation. So you can click on search by significance, and you will get a table of all of the interpretation differences in ClinVar. So how many variants does one group interpret as pathogenic and somebody else call benign? And so you see the ones that I've highlighted in red here are the ones most concerning, most distinct in their interpretations. And in total, there's about 1.2% of variants in ClinVar that have what I would consider medically significant differences in interpretation that would lead a patient to be treated differently. Those are the things we were particularly trying to tackle. Now, I, as an individual lab, having submitted over 12,000 variants to ClinVar that my lab has interpreted, I want to know, well, how do I compare to others, and am I doing a good job? So what are some of the ways I can figure that out? Well, I can click on search by submitter, look up my lab, and get a list of all of my discrepancies with any other lab. How many do I have? Maybe that can allow me to focus on certain labs that I want to try to work to resolve my differences with. I can also get a sense of how do I overall interpret compared to others. So here are my categories of interpretation compared to all other groups. So what I can see is that overall, there's very few of my variants that I call pathogenic or likely pathogenic that others call uncertain, likely benign, or benign. But the reverse is not true. There are many groups calling things pathogenic or likely pathogenic that I would call uncertain. So I can get a sense of where I am on the sort of grading of pathogenicity calls, and then dive similarly into the details of individual labs that I may want to work with and compare myself to and try to get a sense of where I stand in my approaches to interpretation. And we've actually followed up with certain laboratories, this laboratory in particular. Most of our differences were simply between uncertain and likely benign or benign, and it turns out that lab doesn't actually use the likely benign category, and that was why we had differences. But that was helpful to sort of work together and understand the basis of our differences versus another lab where definitely have differences in what we call pathogenic versus VUS. So there's clearly differences in how we're all doing this. It would be great if we had better standards so that we could all interpret in the same way. And so a group of us through the American College of Medical Genetics, collaboration with the American Association for Molecular Pathology, worked for about 2 years to develop a guideline to try to define pieces of evidence and how to weight them and how to combine them to arrive at variant interpretations. This was our group. You can see we're all drinking alcohol here. You'd think we're toasting to the completion of this guideline. No, this was meeting number 1, where we realized alcohol would be required to come to consensus. And that was definitely true. It is no easy task to try to professionally agree with how much weight to give different pieces of evidence and what are all these pieces of evidence. We did the best we could. We came up with a grid of different types of evidence, defining their strength in support of pathogenicity, their strength in supporting a benign interpretation, and then a set of rules for how to combine pieces of evidence to arrive at one of 5 categories, and even just putting out a standard set of terms for how we define pathogenicity for monogenic disorders, is what we focused on, was a leap forward in our field. People were using all sorts of different things, probably, possibly, mutation, polymorphism, and it was hard to even compare. So we standardized that. We came up with 5 terms, and this is the set that ClinVar uses. Everything gets mapped to those 5 terms so we can compare between laboratories. Now, at the moment we published this guideline, a group of us that were working with the NIH-funded CSER Consortium for Clinical Sequencing Exploratory Research. This involves the MedSeq study I mentioned earlier, but there are a number of other programs that are also funded, listed here. We decided to do a bake-off. It's actually our second bake-off. So this time we selected 99 variants from across all of the sites, and we asked every site to interpret those variants with their own rules that they had been using up until that point, then apply the new ACMG guidelines, and we would compare their own rules to the ACMG guidelines within the lab as well as compare between laboratories. So what did we find? Well, when we compared between labs using their own rules versus the new ACMG rules, they were fairly concordant. 79% of the time, using either set of rules arrived at the same conclusion. There were some differences that were found as they applied these rules. However, when we compared between laboratories, there was only 34% concordance in these interpretations, and it actually didn't make much difference whether they were using the ACMG rules or their own rules. So this was surprising. We had thought we'd moved forward. It was 60% if you group benign and likely pathogenic and pathogenic, but still fairly discordant. So we had asked all the labs to define what pieces of evidence, according to the ACMG guideline, they had used to classify variants. So this is one particular variant, the Fabry disease gene, GLA, where the lab's rules, they all called it pathogenic, but using the ACMG rules, they came up with 3 different things. But we asked them to define which pieces of evidence they used, and we walked through each of those pieces of evidence. And I'm not going to go into great depth, but we were able to agree as a group on which rules really did apply and which rules actually had been misapplied. And we were actually pretty easily able to come to consensus on the individual pieces of evidence. Some of this required some education. People had not been able to work with these rules. They hadn't even read the whole guideline, I soon discovered. But in working through these variants, we all came up to speed. Everybody learned the appropriate use of the rules. We were able to agree on individual pieces of evidence. And for a lot of these variants, we were able to actually resolve them by using the rule set. In fact, here was an example where half the group said one thing, half said another. But we went through and agreed that all three of these rules applied. The others didn't. There was one rule that we were of mixed opinion on, but based on those three rules applying, we all agreed it would be likely pathogenic using the rule set. So it became a really great framework to help us, discuss evidence and agree on individual pieces of evidence to arrive at conclusions later on. So in summary, through this effort, we worked to resolve either by email or phone call all 99 variants that had been distributed. We were able to come to consensus on exact interpretations on 70%, or within a confidence level for 85%. Overall, there were 5% of differences that I would consider significant enough to affect medical management. So we didn't do a perfect job resolving everything, but we came to reasonably good consensus. We've also, in parallel, taken this approach between major clinical labs. So this was more of a part of a research study, the CSER program, but we also did a project working between 4 of the biggest submitters to ClinVar. In fact, these 4 laboratories contributed nearly a third of the data in ClinVar. And so looking between these laboratories, we had over 6,000 variants there were interpretations by at least 2 labs that we could compare. We were 88% concordant. 4% of those differences were in this medically significant levels. And we've been working to resolve those. So of 232 differences, we've now resolved 200 of them. 86% were resolvable by simply sharing data. And there's more details about this, but Stephen Harrison, who's a postdoc in my group, and been helping lead the resolution process, is going to talk in more depth about that on Thursday at 2:30 if you're interested in the details. But suffice to say, with consensus and with sharing data from the laboratories, we're able to resolve the majority of these. So what were the lessons learned? Well, as I said, most differences can actually be resolvable through consensus and data sharing. However, it does require professional judgment, and therefore complete consensus will not occur. And I would argue that genomics is no different than the rest of the practice of medicine. It does require professional judgment, and if you go to 10 different doctors with some chief complaint, I guarantee you will get different opinions about how to treat your chief complaint from those physicians. Why is that? Well, it's the practice of medicine. There are different professional opinions. That is true of genomics as well. But I would argue that the evidence should be accessible to all of us so that we're starting at the same ground. And if you're going to use a rule set, apply them correctly. We also, and this is something our group, having made these rules, knew in advance, but that these rules would benefit from added quantitative guidance, so the application of them would be much more objective. And we had to make one set of rules for all genes, all diseases. That's a challenge. And in fact, if we could apply some more gene and disease-specific rules, that would help with more specificity in them. So in fact, if we look at all these individual pieces of evidence that we defined, a lot of them are in fact quantifiable, segregation data, et cetera, and could be aided by an actual tool or resource guiding the application of these rules. And in fact, over the last year, a number of companies have come out with products guiding the application of these rules. And we also have a work group through ClinGen that has been working to work with our different clinical domain working groups that are kind of specifying how to apply these rules in different disease areas. And so this work group is working first to refine and clarify the different ACMG criteria, modify them where they're needed, and harmonize across our different work groups, and eventually move to a much more quantitative Bayesian frameworks that will really assist this in very objective ways. That is a little ways off. So our different work groups are developing specification. This is actually specification presented to ACMG for our RASopathies working group. It's been led by Lisa Vincent, specifying how each of these rules are applied for that particular set of disorders and the genes involved in them. We're also, through ClinGen, building a curation tool that will allow both the ACMG rule set as well as all of the different sort of modifications of it for our different work groups to be able to guide the application of those rules, store all the data. And this tool, which will be launched this year, will assist both our own work groups as well as outside expert panels that may be formed outside of ClinGen to come in and use the curation interface. It will also help laboratories like we're doing now resolve their discrepancies in ClinVar. And frankly, anybody will be able to come in and just curate a variant and export your work after you're done, as well as submit it to ClinVar. So we hope that this tool will really help aid the community in applying a more standardized and objective interpretive process using the rules that we've been developing. One of the outside groups we've been working with is a group organized through the Global Alliance for Genomics and Health. This is a large international organization that I've been involved in over the last few years, I guess now, really trying to develop standards for data sharing as well as demonstration projects. So there's a number of working groups that have formed a steering committee guiding sort of international standards for genomic data sharing, and some of that is done through demonstration projects. So I'll mention two of the ones that I've been involved in, the BRCA Challenge and Matchmaker Exchange. So the BRCA Challenge was really an idea as a demonstration project to say, if we can get everyone around the world to work together around a particular gene that everybody's interested in, and we chose BRCA because pretty much everybody's interested in that, this will form a framework for really international level data sharing and collaboration. So we formed a steering committee around BRCA genes and various subgroups, and the goal really was to improve the care of patients at risk for breast and ovarian cancer through global data sharing and analysis of these genes. One of the goals was to share data through a publicly accessible web portal, as well as along the way address a lot of the issues that we need to tackle for global data sharing and create a model for all disease genes. So we've been collecting data in ClinVar from BRCA1. These are all the submitters that have shared data on BRCA1 and 2. So we have over 8,000, almost 8,500 variants in ClinVar for this one set of genes. But there is data in other databases in other parts of the world. And if you look at the overlap, there is, in fact, unique variants that aren't in ClinVar. We're certainly aware of this. So this effort was to mirror a number of the databases around the world. We've recently launched this BRCA Exchange website as a way to share both expert curated variants working with Enigma, which is an international organization classifying variants through expert mechanisms. So on the sort of clinical version of the website, all of the Enigma classified variants are there. But you can also get access to the sort of research view of the website where you can see variants that have been classified by submitters to ClinVar and other LOVID, other resources. And this effort has been developed both by David Hauser's group at UCSC, Gunnar Rausch, who's co-chairing our evidence gathering group, and overseen by our steering committee. So that research portal just got launched 2 days ago. And one of the parts that I'm excited about that really differentiates it from some of the work we're able to do in ClinVar is that there's a lot of effort in case-level data sharing, patient-level data. In this case, it will require an access process to get access to the case-level data. But that's sort of the next stage of release of this database, is to be able to work with the companies to share their case-level data so that we can identify the evidence to help classify variants. So if we look across all the BRCA1 and 2 variants in ClinVar, 6% of them have conflicting interpretations. A third of them are of uncertain significance. We need to move this field forward and be able to correctly classify these variants. So, and the other thing I didn't mention earlier about ClinVar, on the one hand, we've opened ClinVar up so that anyone can submit interpretations in ClinVar. And that's great. It allows complete crowdsourcing from all over the world. At the same time, it's sometimes hard to decide how to trust information in ClinVar, because anybody can say anything and we don't review it, right? So never say that ClinVar says something. It's the submitter that said something, right? And so we've tried to create a system to allow people to better understand the level of trust they can put into the data in ClinVar. So we have this star system, and the ClinGen program, losing my, actually reviews and approves application for expert panel status or practice guidelines. So we review who's on the committee, conflicts of interest, what the method for variant interpretation is, how things are kept up to date, all sorts of stuff that we review. And to date, there's only so far 4 groups approved in this expert panel status, although we're actively reviewing more, and 2 in the practice guideline. So the stuff that's up there in 3 and 4-star status, you can really largely trust automatically. The stuff below that is subject to opinion. We did separate single submitters into those that are willing to provide their criteria for variant classification, have it posted on the ClinVar website with their submissions. They have to attest to using at least 3 tiers and a thorough evidence review, and either provide their evidence with their interpretations or be willing to be contacted to provide it upon request. So to get the single star, you have to do all those things. And then if all the single star submitters agree with each other, it automatically gets 2 stars. Don't trust the stuff in the no star level. It definitely hasn't gone through as much review. Now, there's still differences, and I wouldn't just blindly trust the single star submitters either, but it helps, guide some level of understanding of the amount of review that these variants have gone through. But one of the challenges I mentioned very early on was, go through the literature and all these variants are reported as pathogenic. How do I get rid of this stuff over time that isn't real? And that's one of the reasons we developed this star system. So if we have classified experts as 3-star, then their interpretations override, sorry, does this work? No. Override the interpretations from other submitters. So you can see that Enigma, an expert panel, has classified this variant as benign. That is now the overall significance, despite other submitters still being in there with other interpretations. So this is how we can, over time, really improve these resources for direct clinical use. So we are forming lots of these clinical domain working groups in different disease areas, focusing on different aspects. I don't have time to go through all the details here. One of our groups is focused on cardiomyopathy with individuals from around the world that are involved in this effort. I mentioned earlier this customization of the ACMG rules for different disease areas. So they have made some general adjustments to the rules. They've made disease-specific thresholds or adjustments to 9 of the rules. 8 of them they haven't changed. They decided 8 of the rules are not applicable to their particular disease area. They added 1 rule, and they decided 2 rules needed to be removed. So this is how our groups are really tackling more specific evidence assessment for their different disease areas. The other thing our groups are tackling is gene-level evidence. So this was Birgit, who's co-chair of this cardiomyopathy working group, assessed through the genetic test registry all the clinical labs that are offering clinical panels for cardiomyopathy. So if you look at across 14 of them shown here, you can see there's very different content in these clinical labs. So there's a core set of genes, the sarcomere genes, that everybody pretty much includes. Most of them are included the storage cardiomyopathy genes. Some include the syndromic genes, but then there's this list, the red genes here, which are just different across all the labs. In fact, 98 other genes, 17 are offered by more than 5 labs, but 68 are offered by only 1 lab. So this is a clinical test that patients with this disorder get, yet you get an entirely different test depending on where you go. Why can't we as a community come to some standard about which gene should be included in a cardiomyopathy test, right? And in fact, what floors me, so I love this figure that Daniel made, looking at gene-level evidence in increasing strength versus variant-level evidence. So there are variants we know are pathogenic in genes we know are associated with disease. Delta 508 and the CF gene. Of course, even with genes we understand are in disease, we find variants of uncertain significance that we don't understand. Happens all the time. We also find variants we don't understand in genes we don't understand. That happens all the time. We usually just ignore all those. What floors me is when people report pathogenic variants in genes that don't have evidence for a disease association. That can't exist. You can't say a variant is pathogenic when the gene hasn't even been associated with enough credibility to disease. And yet I see these on clinical reports. So we need a better standard here. And through ClinGen, we've been working on developing a framework for gene-level evidence. And we've come up with a tiered system for definitive, strong, moderate, limited, no evidence, disputed or even refuted evidence. And we're constantly refining these rules. We've been applying them to different disease areas here, just by way of example. Pheochromocytoma and paraganglioma, clinical tests on the market. Nearly half of the genes do not have evidence for a role in disease. Hearing loss, nearly a third of the genes in clinical panels today don't have evidence for a role in disease. So we're trying to systematically classify gene-level evidence and then allow that to be used to guide the content of clinical tests. So I would argue that gene tests where you're returning predictive information about disease risks, secondary findings, should only include genes with definitive or strong evidence of a role in disease. If you're doing diagnostic panels, you can include the moderate evidence genes as well. The patient already has the disease. You might build a little evidence to bring it up to strong or definitive. But let's leave out these genes from our clinical panels today, leave them for the exome genome when we're going into the unknown already. So a lot of our work groups are actually focused on this gene-level curation even before we get to more of the variant-level curation as a critical step in improving standards. In fact, for our BabySeq project, we've now curated 1,566 genes according to this evidence level, as well as factors like penetrance, childhood age of onset, et cetera. And that's helping guide what variants and genes, in which genes we return to newborn babies in the BabySeq study. Now, there's always going to be this list of genes with limited evidence. What do you do with that list? Well, ideally, we could build evidence over time. And in fact, a project that I've been working on with a large group over the last couple of years is called the Matchmaker Exchange. And here, this is a way to build evidence. So you find a patient, maybe did exome or genome sequencing, you find some de novo variant in an interesting gene that no one knows anything about. So it's a candidate gene, but how do you build evidence? And to build evidence, we want to bring patients with the same phenotype with candidate mutations in the same genes from around the world and match them together. And so we've built a genomic matchmaker. In fact, we've been working closely, again, with the Global Alliance for Genomics and Health and the different work groups on common APIs to allow databases from around the world to exchange data with each other, allow queries to happen in consistent ways, deal with the regulatory and ethical consent process for these different databases and how to exchange data. There's a couple of key papers that have been published for this overall Matchmaker Exchange, but we actually published a series of 17 papers in Human Mutation in September about this platform and how we are using it to match cases to build evidence for causality. So these limited genes either move up the ladder or move off the ladder. Where we are today is 3 databases now gone live and are connected, connecting Canada, US, and the UK. We have at least 5 databases that are very close to launching the API. At the Broad Institute, the Rare Disease Analysis Portal that Dana MacArthur's team has built. The Monarch database actually houses model organism data so that you can match your human patient to model organisms. Genesis and RD Connect are actually piloting a new version of the API that will allow hypothesis-free matching using VCF files. And we're also working with our own ClinGen Genome Connect patient registry to allow patients to initiate the matching of their own unsolved cases. So we're really excited about this. There's a lot more detail that I don't have time to go into, but I will advertise Anthony Philippakis' talk in the data computing track, as well as Orion Busk, who's talking in the clinical genomics track, both who will talk about the Matchmaker Exchange in a lot more detail than I was able to go into today. So this, I think, is a great example of an area we're moving in today where we really talk about federated networks of data sharing, where databases can actually sit in their own sites around the world, yet allow query across these databases, as opposed to the centralized model where everybody has to submit their data into the same place, which is not always possible, particularly when you're working across international boundaries. There's also, particularly some of the commercial platforms, launching more hub-based federated networks. And in fact, we've done that with GeneInsight and the Variant Wire network, where individual labs have their own laboratory databases of variants and genes, et cetera, but then agree to share their data in real time across the network. So we've launched that with GeneInsight. That's been live for a while. One exciting project that's come of that is the COGR network. And Matt Lebo, I forgot to add their names, Matt Lebo and Jordan Lerner Ellis have been a grant through Genome Canada that has allowed taking the GeneInsight software and distributing databases across all of the Canadian labs that do clinical testing so that they can store their data in structured ways, but then allow sharing of the common data across the entire network. And there's now over 17,000 variants across hundreds of genes being stored and exchanged across this COGR open genetics repository. So really exciting ways that groups are sharing data today. I would argue data sharing is becoming increasingly common and enabling increasing success in genomics. Of course, will everyone participate? So far, it's been fairly voluntary. Probably not everyone will participate. And at some level, there may be a need for the stick approach, not just the carrot approach. And so there's ways to think about this in terms of requirement for data sharing with journals. I wish journals would require more data sharing. For lab accreditation, we are having conversations with regulatory organizations that accredit laboratories to require this as a clinical lab. There are hospitals and clinics that will only order genetic tests from labs that share that data, putting financial pressure on these laboratories. Insurers are now starting to ask questions of the labs that they are considering reimbursing, whether they're sharing their data. And I would argue with the new FDA oversight coming on board that whether a lab shares their data in the public domain subject to peer review would allow differential risk stratification of laboratories. Those not sharing might be more subject to oversight by the FDA, whereas those willing to allow their data to be peer reviewed having less oversight. So I think these are all different ways that we think about the future to ensure that we all benefit from broad data sharing, whether it's a carrot or stick approach. And I will stop there. I think we have a few time for questions. If you're interested in this stuff, we have a joint conference with Decipher in the UK on curating the clinical genome. So happy to take any questions. Thank you.